So now we're going to talk about specific types of antipsychotic switching. In particular, in this section, we're going to talk about switching between different oral agents, as well as switching from an oral agent to a long-acting injectable antipsychotic. Different types of antipsychotic switching include switching between two different oral agents, going from oral to long-acting injectable antipsychotics. How do we switch from long-acting injectable to oral agents, or just between two different long-acting injectables? And then a special case would be switching to clozapine. So when we talk about switching between two different oral agents, we often rely on expert consensus guidelines regarding dose equivalence and what dose do you start at, what is the target dose, and what is the maximum dose. Some patients are going to require lower than the projected dose equivalence, and some patients may require a little higher than the projected dose equivalence. And that's okay, but these values kind of give us a guide to aim for as we're making the switch. So drawing from these expert consensus guidelines, you'll see a table here that shows a comparison with 20 milligrams of olanzapine. So for example, expert consensus guidelines would say that 10 milligrams of haloperidol is clinically equivalent to 20 milligrams of olanzapine, suggesting a starting dose of 2.5 to 3 milligrams of haloperidol with a target dose in the range of 5 to 10 milligrams and a maximum dose of 20 milligrams of haloperidol daily. Similarly, these expert consensus guidelines exist for switching between different second generation or atypical antipsychotics. So for example, again, with a comparison to 20 milligrams of olanzapine, experts would say that that's equivalent to about 6 milligrams of risperidone with a starting dose of 2 milligrams, a target dose of 4 to 6 milligrams daily, and a maximum dose of 8 milligrams. So we often kind of rely on these tables when we're making a switch between different oral agents. But again, these are just a guide, and we're going to titrate based on the tolerability and symptomatic response of the individual patients. Similar guidance exists when we are switching patients from an oral agent to a long-acting injectable antipsychotic. It's important to emphasize that when switching from an oral agent to a long-acting injectable, that clinicians need to establish tolerability with the antipsychotic in its oral form before being administered as a long-acting injectable. So for example, if we're switching a patient to haloperidol decanoate, we'd want to make sure that the patient has established tolerability with oral haloperidol before giving them the first injection of haloperidol decanoate long-acting injectable. So this is a clinical decision that's based on product labeling, the half-life of the medicine, and risks and benefits, but this may range from as short as just 1 to 2 test doses all the way up to 2 weeks of treatment with the oral form before switching to long-acting injectable. So an important question clinically when we make this particular switch from an oral antipsychotic to long-acting injectable is how long do I need to continue the oral antipsychotic after the patient's received the first dose of their long-acting injectable? And so the table here below gives some guidelines. For aripiprazole monohydrate, it's recommended that the patient gets 2 weeks of oral supplementation. For aripiprazole Loroxil, it's actually 3 weeks that are recommended. For risperidone, 3 weeks of PO supplementation is recommended. For haloperidol, it could be up to 3 months if there's no loading dose. And so by loading dose, what I mean is that's a strategy to more rapidly convert the patient from an oral antipsychotic to the maintenance dose of the long-acting injectable form with minimal need for oral supplementation. So, for example, if your target dose of haloperidol decanoate is 300 milligrams, the patient may be loaded with 100 milligrams IM haloperidol decanoate weekly for 3 weeks. And this can decrease the need for oral supplementation. With olanzapine, the labeling suggests gradual discontinuation, and we'll discuss this in a vignette of sorts. Gradual discontinuation refers to just tapering the patient off of the pre-switch antipsychotic, so a brief taper off of the oral agent after switching. That's also recommended for paliperidone monthly. And then with fluphenazine, decanoate, the dose is decreased by half after the first injection and then can be discontinued after the second long-acting injectable. So as a clinical vignette here, let me give you the example of Mr. G, who's a 40-year-old African-American male with a history of chronic schizophrenia, cannabis use disorder, and alcohol use disorder. And he was hospitalized for a first episode of psychosis when he was 35, and he was stabilized on oral paliperidone at 9 milligrams daily. However, 3 months after he was discharged from the hospital, Mr. G had an acute exacerbation of psychosis that occurred in the context of substance use and medication non-adherence, for which he required another hospitalization. This is an extremely common clinical scenario. We have patients who go out and use substance, they're non-adherent with their antipsychotic, and they subsequently have a relapse exacerbation of psychosis. But during the hospitalization, the patient was agreeable to a trial of paliperidone palmitate 156 milligrams IM. And so his oral paliperidone at 9 milligrams was gradually discontinued. So he got 9 milligrams daily for the first week after he got his injection, then 6 milligrams daily for the next week. That was tapered to 3 milligrams daily on the third week, and then it was stopped. And Mr. G was fortunate to have an adequate therapeutic response to the paliperidone palmitate long-acting injectable, and he's actually been on this medication for the past 4 years without any subsequent need for psychiatric hospitalization. And just as it's common that our patients are non-adherent with oral agents, go out and use substance and have exacerbation, this kind of a response to long-acting injectable antipsychotics, I think, is also quite common, where we do see folks who engage well with this treatment approach and are able to stay on these agents for a prolonged period of time without the need for psychiatric hospitalization. So, key points for this section: expert consensus guidelines on antipsychotic dose equivalents can help us guide the switch. And if we're switching to a long-acting injectable, we need to establish tolerability with the oral antipsychotic first. Some period of oral antipsychotic supplementation is often required after the first injection.